So program faculty, very pleased to have Nurse Louisa Hope Bruce in the audience, Doctors Tyler Doherty and Brian Esters, Dr. Robert Mendrup, Dr. Connie Rust, Dr. Reagan Shriver, and Nurse Rebecca Yarnell. Very, very thankful to have these participants with us today. So please note that no program faculty have any conflicts of interest, financial or otherwise, pertaining to information relayed through this presentation. And now, without further ado, I'll introduce our first speaker, Dr. Tyler Doherty.
Good afternoon. Glad y'all can join us today with this very cold week we've had. See a lot of familiar faces in the audience, so I appreciate the ones that have consistently come to our presentations and things like that to come again. And if you're new, I hope you come to more presentations that we have at the college. So, welcome. My name is Tyler Doherty. I'm a professor of pharmacy practice here at the school, and I'm going to talk to you a little bit about what medication adherence is and how we can recognize it. So we're here today to talk about medication adherence, but medication adherence is not a new topic of discussion. It's been a very well-known public issue for decades, particularly the 13th U.S. Surgeon General, Charles Everett Koop, once famously said, "Drugs don't work in patients who don't take them." And this is important because no matter how many medications we have to treat all the diseases that we have in the world, it doesn't matter, because if the patient doesn't take it how they're supposed to, they're not going to get the outcome that we want them to have. So it's vital not only what kind of medications we have to treat the diseases, but if the patient can actually take the medicine how they're supposed to. So let's define medication adherence. Previously in the literature, a lot of literature focused around compliance, and hopefully I'm talking a little bit to the social workers here today, but compliance is a poor term to use, because if you think about compliance, it's merely the patient following the directions of the healthcare provider. So a new term came out with adherence, and adherence has the connotation of agreeing with the provider's recommendation and agreeing that it is the right thing for the patient to do to take their medication how they're supposed to, particularly in medication adherence. So again, it's agreed upon action between the healthcare provider and the patient. I also want to talk about chronic and acute diseases. So we know that the literature says that acute diseases automatically have increased medication adherence, because acute diseases typically have more symptoms and they have shorter duration of therapy. So it automatically allows patients to be more adherent to their medication. Chronic diseases, ones that can be permanent or long-lasting, might require a lot of long-term therapy and even special training by the patient. So when I'm talking about medication adherence today, and I would argue most of everyone else that's going to be on stage, they're most likely talking about chronic medication taking. In 2003, World Health Organization convened to talk about this very topic. And they came up with a definition for adherence, which I'm going to read to you. It's the extent to which a person's behavior, whether it's taking medication, following a diet, or executing a lifestyle change, corresponds with the agreed recommendation from the healthcare provider. So again, the agreement between the patient and the provider to change behavior or follow a behavior to betterment the patient's health, particularly medication. So we've kind of defined what medication adherence is. Let's determine how do we actually measure it. So there's different ways to measure adherence. And the first methods are direct methods. So directly observing the patient taking the medicine, measuring blood concentrations in the patient's body, or measuring a biomarker that's released from the drug after it's administered. Now, none of these by themselves are the gold standard. And the reason they're not is because they're very costly and they're very time consuming. So a complete medication adherence assessment of a patient has to incorporate indirect methods as well. So that turns us, what's an indirect method? Well, an indirect method is more of a subjective method. It is a method that you're using patient diaries, you're using patient questionnaires, using pill counts, using refill data in a pharmacy, maybe even measuring a physiologic measurement to determine maybe if the patient is taking the medicine. But it's not actually seeing the patient take the medication, it's an indirect method. So you can see there's pros and cons to both. These methods being much cheaper and less time consuming, but maybe room for more error. So I've got some examples on the screen, and I'll read them out loud. But I'm going to get your all's opinion whether or not you think it's a direct or indirect method of measuring a patient's adherence. So the first example is a nurse visibly administers right therapy to a patient with TB in an outpatient setting. Very common in the United States because the health departments will administer right therapy or tuberculosis therapy to patients because they want their patients to take the medicine so they don't develop antibiotic resistance. So would y'all say that's a direct or indirect method? Direct, yeah. What about a nurse counting the number of morphine capsules remaining in a pill bottle while at a pain clinic visit? So very common in today's world for a patient to go to a pain management doctor and the nurse or the physician to ask to see the the patient's pill bottle and to actually count out how many pills they have left. Would y'all say it's direct or indirect? Indirect. The next one is a medication bottle cap sensor relays information back to the doctor every time the patient opens the bottle. So a lot of new technology is out there right now to where the pharmacy can dispense the medication in a bottle that every time the patient opens the bottle, it relays an information message to the doctor or the healthcare provider to know that the patient opened the bottle. Is that a direct or indirect method? Indirect. Indirect. So it's really important because just because they open the cap doesn't mean they take the medication, right? And I'll hit at some other things around that topic, but what about a nurse measuring a patient's blood pressure to determine if the new lisinopril the patient's been started on and that taking it home is actually working? Uh-oh, I didn't hear very... Indirect? Okay. Yeah, it's indirect. And I think some people might argue that, but a patient's blood pressure could be normal or lower without a medication potentially, depending on what they've changed in their lifestyle since the last visit. What about a doctor ordering a lab draw of phenytoin for seizures? It's direct, yeah, because they can correlate the blood concentration to the actual dose that they're taking. And finally, what about a pharmacist administering a draw tool, which is a questionnaire that can be commonly used in a pharmacy to determine if a patient is being adherent to their medication after noticing upon refill that the patient's refilling the medicine 10 days late? Indirect. Indirect, yeah. So good. So I always put a joke or a cartoon in any of my lectures that I give. And I like this one because it hints at a couple different things. So the doctor's giving the patient this giant pill because they've decided to combine all of the medications into one tablet or one capsule. And what Dr. Esters will talk about here in a minute, and I'll just briefly mention it, is the more medication a patient takes, the more likely they are to be non-adherent to their medications. So this is actually kind of a fairly new concept. A lot of HIV medications, they're being all combined into one pill. I read an article today about it. They do it with antihypertensive, so it's not as far-fetched as the cartoon makes it sound, but maybe just not as large of a capsule. So we've talked about how to measure it, how to measure medication adherence, and how is it actually done in the marketplace? How is it actually done with insurers and pharmacies and payers? So Center for Medicare and Medicaid Services has endorsed certain quality measures that have been created by Pharmacy Quality Alliance, known as PQA. And PQA is a nonprofit organization with a mission to improve medication use. And what PQA came up with and what CMS has endorsed is to look at medication adherence for any patient that is on a Part D drug plan or a Medicare Advantage plan that takes a renin-angiotensin system antagonist, so think ACE inhibitors or ARBs like lisinopril or irbesartan or losartan, statins or medications for hyperlipidemia, and then oral diabetic medications, excluding insulins, all oral diabetic medications. And what they look at is the percentage of patients that are achieving an 80% goal. And what that 80% goal means is that they could miss 6 days in a month of their medication and still be adherent. And that was the goal that was set. It's also important because pharmacies are being graded by these health plans because the health plans are being graded by Medicare to determine if these patients are taking their medications appropriately. And the insurers are actually giving bonus payments or taking money away in penalties to the pharmacies that aren't reaching these goals for their patients. So it's a numbers game as well, but for Medicare, they look at it as a prevention of hospitalization. So they are really pushing for it. Transitioning to what might predict a patient with poor adherence, and I'm just going to mention a couple of them. I think some of my other colleagues are going to talk about them today specifically, but I want to point out inadequate follow-up or discharge planning is number one. It's a big hot topic. Transitions of care right now all across the country, preventing hospitalizations within 30 days post discharge is a huge thing. Also looking at, I think, cost and complexity, like I mentioned earlier, and then patients' lack of insider belief, potentially using motivational interviewing for that, and then just not understanding your directions. I heard a story one time that a mom came and picked up an amoxicillin suspension for her child for her child's ear infection, and the mom came back into the drugstore 2 days later and said, "My child has all this pink stuff in her ear." And she said, "The directions tell me to give 5 milliliters twice a day." Well, she didn't know it was supposed to go in the mouth. Okay? So, one, better education and better notifying by the pharmacist would have helped, but also health literacy helps for the patient as well. So, it's just, that's a great example of education, that how it can make a difference in that patient. There's two types of medication non-adherence categories. They're intentional and then unintentional. So you either choose to not take your medicine on purpose or you don't choose to do it, you have some other factor. So the intentional is the active decision to not take the medication or to forgo treatment. It's often driven by beliefs of therapy. So maybe the patient thinks that the therapy doesn't work well for them, or the disease prognosis, they don't think they have a long time left, or maybe even the objective experiences with the medication, they have a lot of side effects with the medication. An example is not filling the prescription or even discontinuing the medication without talking to the provider, intentional. Some interesting statistic, and these might be old numbers, 15% of all prescriptions that are originally written for a first fill don't get filled. 50% of chronic medications are often discontinued within 6 months. And there's a lot of data to support statin therapy is discontinued within 6 months in about 50% of the population, and those help decrease the risk of recurrent cardiovascular events. Aspirin is another one. It's often discontinued within a year of starting. So contrasting unintentional non-adherence is the inactive decision to forego treatment out of the patient's immediate control. And it's often driven by things the patient can't control, such as driven by health literacy, so poor health literacy, socioeconomic status, thinking about a patient that doesn't have the ability to get to their doctor's appointments or pay for their medications, or just general forgetfulness. If you look at the literature, about 40 to 50% of the time patients report they just forget to take their medication. So you wonder why these different companies are creating apps and phone calls and text message reminders to get patients to take their medication is because it's a highly reported reason that patients are not taking their medication in the first place. Again, going back to cost is another. And then oftentimes it's just a lack of transportation. I think a lot of us have seen those patients that don't have the ability to get to their doctor's appointments or their pharmacy to pick up their medication. And then finally, it's asymptomatic disease. So a patient that doesn't feel sick doesn't remember to take it. And it's not necessarily that they don't want to take it, it's just that they forget. Dr. Esters will now talk about adherence as a public health concern.
Thank you, Dr. Doherty. Can everyone hear me okay? So, just a quick raise of the hand. How many of you in the room feel like medication adherence is a public health problem? Raise your hands high. I would agree. Have you seen your insurance premiums go up over the years? Our healthcare dollars are definitely on the rise. And part of it could be related to multiple things, but one thing could be the medication adherence. So the statistics lie around 2010 when this got a lot of attention, but again, cost of healthcare at that time was exceeding $2.7 trillion to treat healthcare. The U.S. is by far one of the highest dollars in healthcare costs across this world. We spend more money on our healthcare than any other country does. It has been said from those statistics, they anticipated by 2020 healthcare will account for about 20% of the U.S. gross domestic product. And then it said from there, by about 2010, $259 billion were spent on prescription medications. So again, a lot of money spent on medications that possibly may only be taken for a couple of days or may never be taken, again, to the point of Dr. Doherty of what he said behind that. And also, another statistic that's thrown out there is about 35 to 60% of the time in 2010, medication adherence or the non-adherence to medications led to hospital admissions for chronic disease states, whether it be a cardiovascular event from not taking that statin medication, or whether it be from the fact that the patient had an adverse event maybe that they could have prevented if we would have done better education on the forefront for them to fully understood. We could have maybe prevented a hospital admission on that. So again, going back to those statistics, you guys can see it is a major public health concern. We're spending upwards of a lot of money, between $100 and $300 billion just on this problem alone. So here's your numbers. Again, this data comes from 2010 from the National Association of Drug Chain Stores. They said for about every 100 prescriptions that were written at that time, about 50 to 70 are filled at the pharmacy. Well, that's great. Were they filled? Did they get picked up? Is the big question, all right? Because we have electronic means of sending the prescription in. They already have the data on file. They fill it. It goes out on the stocks. But in 7 to 10 days, if it's not picked up, they return it to stock. So we have those numbers. Out of those numbers, only about 48 to 66 of those were actually picked up at the time. And then once they were picked up, they come up with a statistic of somewhere between 25 to 30% of those were only taken properly. So those numbers just keep dwindling down. And then for the patients who did pick up and take, only about 15 to 20 of them were actually refilled as prescribed. So let me give you an example of this. Let's say you're diabetic. You've been on metformin for some period of time. Your diabetes is not controlled. Your A1C, your 3-month marker approximately, is still running high. And, the doctor sits down and he's been detailed by the drug rep on one of these new GLP-1 receptor agonists, like Victoza. He thinks it's the greatest thing. Comes in, patient, you're not controlled, really doesn't sit down with you. It's 15 minutes, walks in the door, assesses. I'm going to send you a new script. Never asked you if you could inject something, if you had a fear of injections, which a lot of our diabetic patients have. But also, what's the #1 side effect of that class of medication? Does anybody know? Nausea and vomiting. It's about around 30%. It's usually very dose related. It usually goes away after about a week. But if no one told you that, and you go and you get that, and you're okay, you're going to inject it. But you start injecting it, and the next thing you know, you're hugging the porcelain god, and you don't know why. And you're like, one thing you can relate to is the fact that you started this new medication, and it's making you sick. You're probably not going to get a refill. You're probably going to stop taking it, and your next follow-up is 3 months away. So we've lost sight of that patient for 3 months. So again, what's going to happen to their diabetes? It's going to stay uncontrolled. We're going to have a possible event. And it's all because we didn't make it very patient-centered. The doctor didn't ask the patient's preferences. There wasn't maybe possibly education around the side effects, that those are dose-related, that maybe if you can survive those for about a week, they'll get better, they'll minimize, all those different things. But about any given time, about 50% of the patients are non-adherent. I'd be interested in hearing, how many of you think you're actually adherent to your medications? I would say I'm not adherent. I'm a pharmacist. I say I forget. I'm the forgetful one. Luckily, I'm not on anything chronically, but if I was, I forget my Flonase at least twice a week. I have horrible allergies. Why would I forget something that helps me prevent those? But I do forget them. So it's a problem that I think even as healthcare practitioners we deal with. So you probably a good portion in this room fit into this 50%. So if we could just take our personal stories and think about why we have problems adhering to our medications and start to relate those to our patients and actually get centered with them. And I think try to figure out what's going on and what can help them around that. Again, you can see those avoidable costs somewhere around 100 to 300 billion. And this schematic here looks at, it starts at the top of the poor medication adherence. From there, you can have poor health outcomes. Again, worsening of diabetes, you get retinopathy, you get renal disease, you get neuropathy, cardiovascular events, what all happens from those different disease states. You get increased service utilization. All of a sudden, you're starting to take up more of our healthcare dollars. This is the reason why our premiums are going up, right? And then we look at other increased healthcare costs, and then a lot of those are passed on to the patient. But what's missing from this schematic? Something cares about. All of us are probably employees or will be employees of someone one day. It's loss of productivity. That's one thing that's not captured here. So a lot of these dollars, that is some of the dollars that are missing, is the productivity. And I'm amazed. Has anybody ever heard of the Asheville Project that happened over in Asheville, North Carolina? Go back and research it if you haven't. It's a pretty phenomenal thing they did around diabetes in the late 90s, early 2000s. And they looked at very much one-on-one care with their diabetic patients within city employees. And they improved medication adherence, they improved outcomes. And all it was more face time. So we know what to do, we just got to continuously do it and improve on it. So a lot of our disease states that are in question, there's no questionable things. It's the chronic things that we deal with, the COPDers, the congestive heart failure patients, the asthma, the diabetes, and the HIV and AIDS patients. So those are our main patient populations that we're looking at with really adherence. And that's been a lot of the focus of the CMS 5-star STARS program, and also the readmission penalties that have happened from CMS back to hospitals. So again, a lot of that focuses on those chronic disease states. It doesn't mean that we are losing other patients, but we also need to concentrate on it.
This is a slide that is more of a perspective from the nursing point of view, which is what I'm doing here. And this was a self-reported study that was done by the CDC. And this looked at why there was not in the chronic disease state, as was mentioned before, that's pretty much what we deal with, is a chronic disease state. Why patients were not taking their medication, and of course the biggest one was they forgot, and that's of course easy to do, but a lot of that you have to look at the age of the patient and their cognitive ability. And that's one of the things that needs, that we need to investigate. They ran out, they were away from home trying to save money. As we talked about before, a lot of prescriptions that, especially the elderly are prescribed, they can't necessarily afford. The side effects, and again, if they're not aware of the side effects, they may quit taking them, or they don't like the fact that they have side effects. Too busy, prescription wasn't working, and we all know there's a lot of people that will self-diagnose and quit taking medication just because they think, well, it's not doing what it's supposed to. Or they didn't think the prescription was needed, or they didn't like taking it. And so, those are the kinds of things that we have to look at in relationship to why patients are not taking their medication. And one of those things that we have to explore, and I think that Dr. Estes is right, a face-to-face time is really important. And we as nurses have that opportunity, and I think that's a good place for us to go.
And again, so going back to that quote, drugs don't work in patients who don't take them. So that's probably, if nothing else today, the big take-home message, and we've got to figure out how to start to bring that together. And again, I think that FaceTime more and more with our patients. So, all right. So we'll move on to what influences medication adherence. Dr. Sminup and Dr. Shriver.
So, buckle your seatbelts. I think we have a lot to talk about in just about 10 minutes. So we want to introduce the concept of some things that are important about social work, and especially how it relates to this concept of medication adherence. So let's kind of take a step back just for a second. We believe as social work that when we are coming to work with a client or work with a patient, that it's really that the patient is within a larger, multiple systemic arena that they're coming from. So we call this a systems approach, that we look at the person is there from the environmental perspective. They have a biological system that they're in. They have a social system, which includes family and coworkers and all that kind of stuff. So there's all these systems that a family or that an individual is a part of. And then we also think about we use the phrase person and environment. So when we talk about medication adherence and this work that we're doing with our collateral professions of pharmacy and nursing, that we think about how can these systems come together to deal with what we call social determinants of health. And so that's a big discussion. I'm sure you all talk about it in pharmacy and nursing school, but it's a big thing that we talk about in social work. So this is just, I think that medication adherence is one aspect of this concept of social determinants of health. So just to kind of continue to beat the drum of social determinants of health a little bit, look at this. In the year 1900, this is 1900, so the leading causes of death, you see there pneumonia, tuberculosis, bad diseases, heart disease, stroke, all these things that were occurring. These were the causes of death. Okay, now compare this to 2007, which is 10 years ago, but still. So look at that. Heart disease, cancer, stroke, CLRD, accidents, which now I've been informed is now moved up to fourth. Accidents is now fourth cause of death. Alzheimer's, diabetes. So what do you notice? What is the difference between this one, these causes of death, and these? Any thoughts? What might be connected, or what might be a line drawn from these causes of death to something? What? Any thoughts? Immunizations. So a lot of it could be tied to behavior. A lot of it's tied to behavior. You think about the leading causes of death in 1900, pneumonia. We have medication for that now. Tuberculosis. These are diseases that were occurring. But then you think now heart disease, that can be managed by taking your medicine, exercising, your diet that you have. Maybe cancer might be something, strokes, that kind of same thing. So we can kind of draw lines to personal behavior that have impacted what is making people sick and making people die. Here's another thing to look at with this discussion about social determinants of health, and that's the region, the geography or zip code where you're from. You think about that, this is in North Carolina. And look at that, the bottom map of North Carolina there. The brown is the highest rates of premature death. So you can see those counties in North Carolina that are colored in brown. Then kind of back up a bit to the next map of North Carolina that shows the percent of people that are uninsured. And you can kind of match up. Where there's premature death, there's higher percentages of people that are uninsured. And then if you back it up to one more map there, you see the percent of people in poverty there. The counties with the highest percentage of people with poverty also have the highest numbers of people with premature death. So poverty is correlated with a premature death as well, because of diet, because of poor housing, because of poor clothing, because of poor stressful situations that people live in because of this situation of poverty. So here we could talk about all these things about behavior, environment, your zip code, where you're, all these different things that play into a person's kind of overall health picture, which adherence to medication is a part of that. So let's talk again. This definition was brought up once, but from the World Health Organization, and I think I'm here, little me. I'm the last person that I should be criticizing what the World Health Organization says. But I feel like that this definition does not include this person in environment situation. If we are only looking to the person's behavior, if we just say, well, you're not taking the medicine, you're not taking, well, what system are they drawing from that is behind them or around them or encompassing them? What things in in this scenario, in their larger system, might be impacting their choices of behavior. So you think about like, if maybe you could say, well, my behavior is I'm not taking the medicine. Well, that's something that's my individual behavior. But why am I not doing that? It's because maybe a societal belief that I shouldn't be taking this medicine because it helps me with depression or a mental illness. Society says that there's a stigma against people for taking medication because of a mental illness. So that could be a part of a systemic factor in why the person isn't taking the medicine. So there's all these things around the person that are driving that. So maybe I wish that the World Health Organization could maybe like rewrite this. Maybe say a person's larger system that impacts or develops their behavior, something like that. That would be a good thing to think about. So, but the great thing the World Health Organization has done is divide up 5 dimensions of adherence, of adherence to medicine. And you can see them there. Social, economic, healthcare system from which the person comes, the conditions that are related to this, therapy related, and then patient related. So I'm going to talk briefly about social and economic dimensions. So we could talk about all of these very to a great extent. We could stay here for hours talking about all this stuff. But limited English language proficiency, that's something that maybe could be worked with if you're using pictures or helping people have access to other languages. You know, like something like if you're supposed to take it at night, draw a moon for the person, do they understand? I mean, kind of things like that to try to have that hurdle sort of bridged. But a big thing to talk about is the low health literacy. This is something that we've already mentioned here today, but the low health literacy is really about obtaining and processing and understanding basic health information. This is something I feel like that a lot of us run up against, that people really don't understand what the medication is going to do, what's going to happen. If somebody has a mental illness, do they have a distorted view of what's going to happen? I used to work in an eating disorder unit which treated anorexia and bulimia. The patients were a psych tech who also had low health literacy, that the medication might make them put on a few pounds. That's the last thing you would tell to an anorexic patient, that this medicine that you're supposed to be taking is going to be fat on you. So that's just an example of this low health literacy thing that can really just wreak havoc. And I think this is something about what is our responsibility as healthcare professionals. How are we educating and providing that information in an understandable, clear way that they can get it? It's a lot about, I think, informed consent is that we're missing something. I know all 3 of our professions would believe in an ethical value of an informed consent. And I think that this is where we're making sure that our people really, truly are informed. One more thing. Connected back to poverty is this issue of homelessness. I worked at a place before that it was a housing facility, and people that were homeless came in, often not having taken their medicine, and they were all their labs and all that was all goofed up. They looked physically having a tough time. Boy, once they get on the medication, have people supporting them and taking it, coming in off the streets, life was a lot better. You think about this burdensome schedule. You think about it. If you're in poverty and you're working 3 different jobs, and cleaning houses in between or something, when in the world are you going to be able to go to the doctor during the time or the pharmacy to be able to, the hours that they're open? So those are all things to consider and think about. Also, a couple more things about social economic conditions. One thing I'd kind of like to highlight is this idea of elder abuse. I know we have some of our friends that are working with this population. Did you know that 11% of the population between the age of 60 and 85 are abused or neglected in some way by their primary caregivers? This is a big number, 11%. That's more than 1 out of 10 of the people that we see that are 60 to 85 are in some way being abused or neglected. And a lot of this goes back to medication stuff. So maybe the caregiver might be giving benzodiazepines to the person they're supposed to be caring for, just to kind of keep them in their room quiet, or not give the person the medicine which keeps them awake or whatever, to keep them in their room by themselves or whatever. So this happens. There's a place called Samaritan Place here in town where we used to be part of an agency that I ran, and we would see that a lot. Clients coming in where the caregivers were taking complete advantage of the medication that the elderly people were supposed to be taking. I think that's a big consideration when we look at social and economic conditions. So that's my part, so I'll turn it over to Dr. Mendel.
And I think I had like negative 2 minutes.
Oh, sorry.
We'll go through this. Some of the stuff that I'm going to talk about, we've talked about indirectly and some directly, but a lot of what you're going to hear from me today in a short amount of time, and also down on the panel, is my experiences working as I say, a social work informed clinical psychologist working in primary care teams, particularly with integrated healthcare. That's a lot of what my practice experience has been. Primarily working with individuals with chronic healthcare conditions, which has been a theme of what you've heard so far. So that's a lot of the lens from which to frame my discussion. So I think one of the things that's really important that we see, particularly with individuals with chronic healthcare conditions, is they have multiple providers, and generally those multiple providers aren't in the same building, right? And they're in different locations, and so the degree to which they're talking with each other about what medications are being prescribed, the degree to which a patient is going to be able to remember all of those things and all those changes that continually happen when you have multiple chronic health conditions. So that's one thing that I'll highlight in the slide here. There's other things I think we've talked about already. Of course, we know long wait times, short visit times. Primary care, you're looking at about 15 minutes. So that's a lot to get into one visit. Related to something on the earlier slide was the provider and patient relationship, and a big part of that is communication, right? And so I think that communication, listening are essential things for our patients to be able to know how to take medication, what it's used for, and all the things that they should be known about when it relates to their medication. The other thing I'll just mention really quick that I think is something that's not addressed often in healthcare systems, which I've been a part of, and here in the state and also in other states as well, is that any person who has any professional contact with a patient should be informed about medication adherence, should be knowing what's going on with the patient. It should not just be left up to the nurse or the primary care provider to know that information. So anybody who touches a patient in any sort of health capacity should be informed and educated on medication adherence. Again, chronic health conditions, we've learned already today that the more chronic health conditions you have, the more medications you have. And again, it translates to poor medication adherence as that increases. A big part of what I do, a big part of social work is being able to assess and intervene on behavioral health issues. And I like to add behavioral health issues into chronic health conditions as well, because the great number of patients that I've seen in primary care, not only do they have diabetes and COPD and hyperlipidemia and hypertension and so forth, they have some behavioral component to it as well. And it makes sense. And to see how those things interconnect are really, really important. Lack of symptoms, I've had multiple conversations with patients who have hypertension. We know the silent killer, where I think it's 10 to 20% of patients with hypertension have any sort of symptoms or that they can recognize, and so you might imagine it might be really hard to take medication if you really don't feel like you don't know whether it's doing anything unless you take your blood pressure. So those are things that I see quite a bit, and those are obstacles that we face when we're talking about medication adherence. Side effects, some of that's been talked about. I think my experience has been is that the patient, if they are informed about what side effects are, think that it's just a certainty that's going to happen. And of course, we know in reality, we're talking about percentages of patients who might experience certain side effects associated with the medication. So I think being able to articulate that's patient-centered and directed toward the patient depending on what medication they're on. And then a big one, a huge one that Dr. Shriver's talked about and others have talked about as well, is that yes, we're talking about medication adherence, which is a very large behavioral sort of issue, decision-making that the patients are engaging in. So when we're talking about chronic healthcare conditions, we're not just prescribing medication to a patient with diabetes, we're also talking with them about their diet, all of those things that, and exercise that factor into that ultimately determine whether a medication can be successful or whether the patient's treatment goals are successful. Patient-related dimensions, some of these we talked about. Motivation is a huge one. Again, if there's a lack of symptoms, it might be difficult to think about, to remember to take it or to see the value in taking it. I often find that a lot of patients, particularly in chronic care, and a lot of my work has been in rural healthcare settings as well, is that patients are prescribed all these medications, but they don't know the disease processes well enough or informed about why it is they're taking it. And so it kind of undermines the rationale for them to take the medication if they don't really have a good sense of what diabetes is. And so that's really important that that's addressed as well. And I think some of this we'll cover in the panel, but I think that covers our portion of the presentation.
Okay, as our presenters make their way to the chairs at the front. I'd like to thank each and every one of them for participating. And it was very interesting to see the topic of medication adherence being addressed from different frames of reference, from nursing, from social work, and from pharmacy. It also brings home the point that looking at the patient through patient-centered lenses, looking at the person in the environment, it's critical. Because I tell my students in communications class that the patient is the expert in how they take their medicine, and we need to learn from them on how to do that, how they're taking their medication. Panel discussion. I need to run up here and change the slide. We have 3 questions on the slide deck to just prompt discussion. But here again, I invite all of you all to ask questions, to participate. If you have any experiences that you would like to share with the group about your patients and how they're taking their medication, please by all means do so. First question, what are the most common reasons for non-adherence among patients that you see in your practice? Okay.
I also have I'm a minister as well, so I feel like that some of the things that I've seen are like people are doing some kind of fasting thing that sometimes because of a religious background, that's a cultural issue. So then how do you communicate to to the person that some religious thing, or like if it's Ramadan and the person can't eat all day, then but the medicine is supposed to be taken with food, is that considered? And they're not even supposed to drink water. Then I would encourage people to talk to their spiritual guide or their minister. And I think in most cases, a minister would be able to say, okay, well, God or whatever wants you to take the medicine. So that's just another cultural kind of thing that I felt kind of from my experience. I thought I was brilliant. So.
From the nurses' perspective too, is a lot of what we see is a cost factor, especially for patients not able to afford the medications that they're given. And a lot of times it will be a situation where they're prescribed a new medication and they then have to make the choice between that new medication and maybe something else, either another medication or even food. So that's one of the things that we see. And I think another big factor is they don't understand why they're taking the medication. And I can't tell you the number of times where somebody will, down 6 pills, but they are not familiar with why they're taking them or what they even are. So I think that's a big factor of educating and helping them understand what those medications do.
I work in a very rural pharmacy in Anderson County, and kind of echo cost. Cost is definitely a huge barrier for a lot of our patients, especially on brand name products. But also, I think the number of medications they take, I've got a couple of patients that they take upwards of 15 to 17 medications a day. And then the other is transportation. Surprisingly, we have a lot of people that have transportation issues just to pick up the medication. And so we try to combat that with free delivery. We try to deliver 3 days a week for our patients. So, but I think those 3 are definitely one of our top 3 reasons that we have issues with that.
Can I follow up on the ones that I have patients that have like 20 medications, and I just can't believe that that's the right thing to be doing. What do you do about patients?
So it just depends if they're as needed or if they're chronic medications. As far as us, we make sure every medication has a disease to go along with it, first off, and then we try to help in any way possible, whether it's packaging, bubble packing to help them organize their medications appropriately, or just organization I've found has been the best thing for them. But really talking with them and finding out why they take each one and how they take them is the best. But you're right. I mean, there are some patients out there that do take upwards of very excessive amounts. And I think the first thing is to start to make sure every single one of those medications has a reason, appropriate reason, and that it's being monitored appropriately.
I think to echo on that, another thing that I've seen, probably to your point, when you do discover that and they're on so many meds, is they come from multiple doctors. And then you'll have primary care who doesn't want to touch this doctor's meds, or you got a specialist who doesn't want to touch this doctor's meds. And how do you handle that? And I think it's that communication across the board that we lack so much in our healthcare profession, of being able to talk amongst our providers and figure out what happened. Yeah, we sent you to a GI specialist, now they've added 2 or 3 meds to it. How long were you supposed to stay on those meds? You know, and nobody wants to touch those. And that's something we dealt with in my practice when I was fully active, and I practiced at non-federally qualified healthcare agency. And, you know, we deal with all kinds of patients coming in, and sometimes they come in with big, large brown bags. And sometimes they were even, the PRNs were the worst to try to get rid of us. Oh no, you can't take that from me. I gotta have that for this instance, and I gotta have that for this instance. And so I think it goes back to some of the points from the social work side, which is the behavioral health. And that's something we try to do is, you know, try to treat that as a whole body. We try to treat the behavioral along with the primary care side of things. And if you can somewhat master that, hopefully you can help start de-escalating some of the drugs and get people talking. That's the only way you can have it. And I've sent recommendations, I'm sure Dr. Doherty has, and the doctor just will absolutely not take anything away. I mean, you've got duplicate of meds going on.
Well, the patients tend to take the little ones and not swallow the big ones.
Yeah.
I have a question too. So we know that the doctors are prescribing and the people are taking the medicine and they're probably not taking it. We deal with the elderly a lot. And I'm just wondering if there's ever an instance where a pharmacist realizing that a person is not taking their medication and finding for whatever reason they may have a cognitive issue, they may not understand it, they usually it's cognitive for us. So is there ever a time or is there ever a way, or even on the horizon, that a pharmacist can recommend home health for med management? Because the doctor doesn't know. The patient goes back and says, oh yeah, I'll take my medicine. Well, if there's not somebody in there with them to say, oh, no she's not, no she's not, then how do you, there's such a disconnect there. And it makes sense to me that a pharmacist would be able to say, these people need help in their home.
I think for my practice, I was again in a primary care doctor's office. So that was very easy for me to do when I picked up on that, was to walk over to my nurse, the nurse that's with the provider themselves, and recommend that. But I think from Dr. Doherty's standpoint, being in a community pharmacy is, again, how do we get the nurses? Everybody's so busy. And that's what we've got to be able to break down in some of that time barriers that all of us have in our professions. We're getting asked to do more with less, and how do we manage that before we can communicate openly? I think that's the struggle. I mean, if you've got a pharmacist that's built within primary care, which that's not many here in East Tennessee, it's becoming a bigger trend, then those referrals to those pharmacists in those clinics, and then when they can walk straight to the provider and say, we need home health for this patient, or we need to de-escalate these meds because we've got a patient who's deteriorating, and do we need to continue these chronic meds anymore? You know, so we can simplify things and make life a little bit better. Mama, daddy, grandma, granddad, whoever it may be.
And I'll echo communication. I mean, but you know, when I'm at the pharmacy and I'm looking at a patient's profile and they haven't refilled their blood pressure medicine or any other medication in 65 days, and they got a 30-day supply, and they've been on it for a while, I mean, that for me just hits the nail on the head right there. It's like you see the patient and then you talk to them, and they claim that they're taking it, and you try to do everything that you can to break down that barrier to find out maybe why or what's going on. And you know, sometimes you just can't figure it out. But I agree. I mean, there needs to be a better way to be able to you know, notify and communicate about those types of patients and accepting those recommendations. So,
They'll stockpile. They'll have 8 bottles of blood pressure medicine.
So I have a question. I'm a pharmacist, and my question is I'm not aware of what you're talking about. I get that there's home health care, but home health care to go in and help with meds, I don't know that pharmacists know what the resources are that they can call the doctor and say, hey, this patient is a candidate. We just don't know that unless you have personal experience where you had an older person or somebody that you were help them with that. So I think some community resources that are available and get that information out to community pharmacy would be a great takeaway from this thing to get it to help us get the patient tools.
I know with the retail pharmacies, they do MTMs. Is that something that go out to the community pharmacies?
So can you repeat the question again for me?
I know with the retail pharmacies, like when I work at, we do MTMs, which is pharmacist talks with the patients, goes over their medications, and then sends emails to the doctor to say, well, this can be changed, or, you know, maybe this medication can be stopped, or they can make recommendations. Is that something that can be sent out to community pharmacies?
I definitely agree it could. A lot of times the big barrier for me is probably over 50% of the time, and I do MTM with all the platforms available every day, and the problem with me, probably 40% of the time, I can't reach the patient. And a lot of time it is the area that I practice because we are a low socioeconomic area. And they change phone numbers, they change cell phones, they change numbers so often that the only cut point I can have is when I actually see them come in the store. And I can then document everything that I need to do through that experience and then send the doctor a notification that, you know, the patient's having trouble taking this. I think communication with the patient, just in terms of getting a hold of them, is one of my biggest barriers and where I practice.
So how often do you see non-adherence because of either medications being stolen by like other family members or even intentionally shared with other family members if they know they're on the same medication or does the same thing or they have the same chronic illness? Is that common?
It is. I think it depends on what you're treating and what the medication is. You know, probably to share your blood pressure med, probably not going to happen. But something when you get into some of the other, obviously, pain meds and even things like neuron, that was one of our probably highest things in our clinic that we saw a lot of shared was gabapentin and neuron. At that time, we shared amongst family members, but I don't know that I really saw anybody sharing their metformin with their family member. But they would stockpile things and then try to self-diagnose and self-treat. Maybe their other family members like, well, I've got this antibiotic, do this. So I'd see some of that, but not really chronic meds, I don't guess.
I was going to say, I see that quite a bit with antibiotics, particularly in rural areas where one family member is the one that's identified patients who can go, but they all have it, and so they think that they sort of just share it, that they'll all get better, and so that just undermines the whole process. So it's not something uncommon for us to see.
This shelter that we ran when I was working at Catholic Charities, it was for seniors, people 60 and older, and that was a really, regular occurrence that the patients would come, or the clients would come in and their family members had taken their medicine or we had taken it from them or misused it somehow. So even then, this is my own dad. They used to go to Hardee's every day and have coffee with his friends, and some friend of his gave him some medicine and said it made him feel better. So started taking it. His doctor nearly. If he didn't die from that, my doctor nearly killed, or his doctor nearly killed him. So, so it must be happening.
I'm a nurse practitioner, and I worked my entire career in public health. And it was in the primary care setting, all of our patients were uninsured, so we provided the medication for them. So really the cost wasn't an issue, but there were so many social aspects of their lives that made it just impossible for them to stay to be at home. And so I feel like that the social aspect and what's going on in that patient's life at home has almost more to do with the cost.
feel that you're right. And I think sometimes it's like if you're a caseworker, you know, or someone external to the medical system, it's almost like you have to do like some sort of investigation to figure out, okay, what is the pinpoint? What's the problem here? What's in the person's mind? Or what is the issue? It's almost like doing an investigation to figure out what's preventing them from engaging, you know, as they've been prescribed.
I think there's a cultural component as well, because I think some patients don't feel like they can ask the questions that they need to ask. You know, and so there's a shame factor there. The doctor finds out that I'm not taking it the way I need to, and so I think something you'll hear more about maybe in another question or two is just the role of that relationship and communication, not just with the prescriber, but other members of the healthcare team, and how that can be so crucial in providing optimal care and having the patient taking medication, you know, in a successful way.
Which I think is important about the language. I think that I like that we've switched from compliance to adherence. That I think there's something important about a language that creates a barrier. I'm here telling you, poor thing, what to do, but really we need to be in it together. We want to lock arms and walk together through this difficulty you're having. I'm here to support and help you. And if we convey that kind of an image, yeah, I'm an educated person, and when I go to the pharmacist, I feel kind of like a little guy, like, you know, like I feel a little embarrassed about it or whatever. And there's all these people. I don't know, but then sometimes when the pharmacist is nice, it makes all the world of difference. I feel more comfortable asking questions. That's just my experience.
I once heard a lady talk that was, I think she had a PhD in literature or something, very well respected in her field, and she went to the doctor for a chronic disease, and they'd given her medication, and she asked a question about it, fully didn't still understand from the literacy standpoint, very well educated, went back again and asked the same question, asked it, and still couldn't get an answer she understood, so she just chose not to take the med, because she was too embarrassed to continue to get to a level where she could understand, and that's someone with a PhD. So you take it someone like my dad who quit school in 7th grade in rural Kentucky and worked on the farm, he's not going to question or ask any further. So I think that's it. It's more, as Dr. Russ said, more face time. And that's something I saw in my clinic. When I came into my clinic, I ran a community clinic. They told me, oh, patients won't come to these appointments. And sure enough, in the beginning they didn't. But as I spent more time with them and had more time to explain that disease process and what we're trying to do, when I left that clinic, my compliance rate was about 85% of people showing up to their appointments, and it was sitting at about 50 when I started. So I think it's just more face time. And obviously I had a lot more time than the providers did. They were in and out in 15 minutes, and the nurses. So I think that's what's hard. If we could spend some more time with these patients and really get them to understand. But the thing is, they would take their Coumadin, but they wouldn't take their diabetic meds. And I wasn't treating their diabetes. So if I could got on the other spectrum, I could have got their diabetes probably controlled too. And you'd ask them, it's like, well, I see the importance of this, but I don't see the importance of that. So I think it's, again, understanding more face time.
This is wonderful. So glad that y'all are interacting and discussing. Second question, what methods are used in your practice to determine patient medication adherence?
So for me and my students, we do MTMs, which if you don't know what that is, we call patients that are kind of flagged by insurance companies. That's one way. We also use medication refill records, which, as I talked about earlier, is not necessarily the best way, but it is a way to kind of flag patients. Another great way we do it is I always ask patients in a given week, how many doses do you miss of your medication? And I try to ask it the least insulting or demeaning way as possible. I can just say, how often do you miss a dose? Is it once a day, twice a day? And oftentimes that open-ended question will get them to respond and tell me, I miss 2 doses a day, or 2 doses a week. And it's like they find out what time they're missing. And I think, like Dr. Esther said, it's really either FaceTime or just talking to the patient. And if you can get them to talk a little bit more, you find more and more about their history and about what's going on. And a 30-minute phone conversation later, you find out what's going on, and you can maybe give a solution to the problem, whatever that may be. So,
I think to add to that, I mean, I think what he was saying, but to validate also at the front end is something we do a lot, is saying, you know, potentially depending on what the patient's on medication for, you know, it could be really overwhelming to be on the number of medications you are on. I'm sure there are times where X, Y, and Z, and so you're kind of throwing it out there and seeing how it lands, but it does a lot of ways of being able to empathize, but also validate the struggle that patients have, particularly ones who are taking lots of medications, to open that door to have those questions where they feel comfortable and not like they're going to be shamed because they're asking specific questions. So I think that's a really good point.
I like the way you worded it. Like, how many did you miss? I mean, it just assumes, yeah, we're all going to miss it, occasionally, rather than you didn't take, or you took your medicine, right? Then that's going to, oh yeah. I like the way you asked it.
I think it's building relationships. And build those relationships with your patients, and they know to the point you're not going to shame, but you're there to help them. And I think it goes back, I think one of the best things I heard from your guys' standpoint was the environment. What barriers do you have? Asking those questions, like, what's going on? What can I help you with? Is it affordability? Is it transportation? Or is it, I work in the middle of the day and that's when this med's prescribed, okay? If that doesn't work, then can we change the time or can we change the med? Something that fits your schedule.
Are any type of self-report measures that are used, like in risky, any type of surveys that are used?
I've done, you're talking like the draw tool? I've done the draw tool. Again, it's got its flaws. I've tried many others, but that's the quickest way that I found. There's a 10 questions. 10 questions are usually pretty easy to ask, so I've used that one.
Yeah, that one kind of helps you identify like maybe different reasons and solutions that you could help with the patient. Dr. Russ was talking about the risky scale. It's a 3 or 4 item. There's a 4 and 8 item questionnaire, and it's got some data behind it, whether or not how they answer the questions can support the likelihood that they're actually not taking their medicine as prescribed. So those are some tools, but we use the draw tool somewhat. I haven't had a whole lot of experience with risky, but I've read about it. So.
Here's a question.
I was just going to say that I think it's important for the patients to know what they're supposed to do if they miss something. I just visited my grandfather last week and he's like, oh, well, if I realize I forget it in the evening, I just take both. And it's supposed to be like, one in the morning, one in the evening. And I was trying to explain to him that it's like not good to do that. And he's like, oh, well, I feel bad for missing. And so and he just didn't really understand how important it was, to not take that one in the morning if you missed it, double dosing at night. And I think that's important because so many people are missing. Well, what are they going to do when they realize that they missed?
Okay, question 3. What strategies are used in your practice to help improve medication?
One of the things that I do often in practice, working with primary care providers, is particularly when a patient's being prescribed a medication, one that maybe they're not used to taking, maybe it's several times a day, is how do they integrate that into their daily routine, right? It's a new behavior, or it's an extension of other medications they're taking, and so what I will likely do is I'll spend time talking with them about sort of what is their daily routine, what are, when they get up in the morning, what is it they do, and try to latch on an already existing behavior that they're engaging in, let's say brushing their teeth, as a way to increase the likelihood that they're going to take their medication in the morning that they need to take. So I spent a lot of time just getting to understand the patient, their behaviors, and to be able to shape that behavior with something they're already doing and seeing tremendous success in doing that.
I agree, I've done the same. I think the other thing that I've learned over my years of practice is the pharmacy is handing that prescription bottle back and saying, what does this mean? The language I just put on this bottle, what does that mean? So that way you don't get the amoxicillin in the ear. Because we forgot the word oral. Give orally or give by mouth. We forgot that language in there. But what does each direction mean? What does twice a day mean? What does 3 times a day mean? What is, and trying to get down to the root of that to see if they can understand how to even just interpret to take the medication. So I think that's been a big help. The other thing, a lot of the patients I've dealt with sometimes don't read or write, and it's still, believe it or not, that's a very more common problem than I think we think exists. And so it's very hard for people to admit that. And so one of my tricks of the trade is I would usually give them a piece of material and I hand it to them upside down to see if they'll flip it. It's not a foolproof, but it's a good way to approach it because they'll see the words and are they just going to ignore it or are they going to flip it back around? And so that kind of gives me a little bit of hint. And then do I need to turn to developing, like I said, like you guys said earlier, I did this as a student for several patients in Kentucky, but the picture mechanism, the sun, the moon. And sometimes you got to ask, what do you associate with morning? Is it the sun? And I had one guy tell me one time, chicken. So what he associated with the morning because he had chickens and he went out and got the eggs. So guess what? His AM meds had a picture of chicken on them. I mean, that worked for him. And so, you know, it's getting down to that, just not assuming the sun is what he associates with the morning. He assumed chickens because that's what he did the first thing when he got up. He got his eggs. He's a farmer, so.
For us, at our pharmacy, I went to a conference one year and heard about this idea of med synchronization. So filling all of a patient's medications at one time every month, and then checking in with the patient 28 days later, and then going through a whole spiel again with the patient. And it frees up a lot of workflow for the pharmacy, but it also helps the patient in terms of return visits. So if you take 8 medications and you have to pick up 2 medications each week, well, the patient's making 4 trips to your pharmacy, and so why can't you make it easier for them? And so I gradually started doing that, and we're up to about 75 patients. And I've got some people that take 3-4 medicines, and I refill them all together after calling them and talking about what they're for, how are they taking them, have they had any recent hospitalizations, have they been to their doctor recently. And then I get to know them that way really, really well because I'm talking with them every month, and they get to know me, especially when I haven't been at my pharmacy for that long. So they get to know who I am. And then I have touch points with them every single month. And then I'm putting everything in one bag for them. So when they pick up, they know that everything is for a 30-day supply. And a lot of times we have patients that come in that are getting their pain medication refilled, and they get it every 30 days on the dot. But they don't get their diabetic medicine every 30 days on the dot. They get it every 40 days or every 45 days. So when we synced up all their medications, it was like something inside of them said, okay, I'm finishing my pain medication every 30 days, but why do I have 15 more days of my diabetic medicine? It was literally like they were in pain, so they were taking their medication, but they didn't know that their blood sugar was so out of whack, and they would forget to take that. And so I think kind of internally they begin to realize, oh, I need to be ending on the same day for everything. And it's been really successful for us, and I think the patients have really enjoyed it. And sometimes it can be a cost barrier, depending on the type of insurance the patient has. But that's what we do a lot of the time.
Okay, Dory, did you run into any roadblocks with third-party payment needing to be up, and how would you handle that?
Yeah, so her question is about costs and third-party payers. So most Part D patients, Part D plans will allow for that to essentially short fill to make everything match. So only given a short amount of supply, so that way everything ends on the same day. Most of the commercial payers that are not Medicare eligible are really a mixed bag. Most of them actually don't help with that. And so a lot of times you have to center it around the most costly medicine and then fill everything else, short fill it for cash for those. But again, those are the patients that are between 18 and 64 that have commercial insurance. So they're not as caught on yet, but there's laws that are, bills that are going through different states right now that are trying to promote it. For example, in Tennessee, there's one going through the House right now, I believe, that's promoting medication synchronization that has to be allowed for insurance in the state of Tennessee.
So did you have, when you started working towards synchronization, is this something that the patient discussed with their doctor, or is this something that you discussed with the insurance company?
I discussed it with the patient.
With the patient.
Yeah, so I came up with high-risk patients that weren't refilling their medicines appropriately, or maybe even ones that just took a lot of medicines, like 5 or 6, and that they were separated throughout the month. And then I approached the patient at the point of sale or at the counter and just said, hey, this is a free program that we're offering, and we're just starting it, and I wanted to tell you a little bit about it. And the way I pitch it is you make one trip to the pharmacy, you'll get called 3 or 4 days before the medications are due, and we'll talk about all your medications again, have a touch point, find out if you've been recently hospitalized, if you've been ill, and then we'll talk about any of the medications you have questions on, and then we'll put them all together for you so you don't have to make multiple trips. And whenever they hear that, as long as they're not paying more for something, most of the time, they're good. So sometimes you get patients that are really prideful, and they're like, no, I want to manage everything about everything, and I can only offer it, but most of the time, it's got a very good perception.
So do you have
the people who are stuck on that 90-day mail delivery through their Part D, I hate those. I don't trust them. I don't think they get the medicine there in time, a lot of times. So, do you all, and this is just a question that I have, do you price match with those? Can you compete with those prices? Because that's a big deal for somebody that's about $700 a month.
Yeah, they get them for zero.
And they get them for nothing, or they get them for $10 for 90 days.
Yeah, I'll give you a good example. A lady was on 8 medications, and I synced all of hers, and she was Medicare eligible, and I actually got her synced on 30-day supplies, and the week after I got her synced, her insurance called and said, hey, we'll take care of all your medicine for you, and we'll, and no copays or reduced copays, and we bill the insurance, and oftentimes we don't get the same price, the patient doesn't get the same price through us. And so we can't necessarily match that, but it really frustrated me because I made a point to help the patient, and then now they're just going to kind of send it. Yeah. So.
Yeah. Okay.
I think another thing to Dr. Doherty's point, very important, is being sure that as you guys go out and talk to your patients, the importance of getting to know their pharmacist and staying at one pharmacy if all possible. I think our profession over the years, as we've had drugstores pop up on every corner and our mom and pops have started to go away for various reasons, we're not thought of as the practitioner that's there. You know, you don't skip, most people don't skip around doctors, do you? You stay at your right, you go to the same doctor, and you see hopefully the same nurse, a nurse practitioner or PA. But pharmacy, we have people that move from store to store, but I think if all possible, they can get to a pharmacy and stay there, they'll get to know the pharmacist who are regularly in that store, and they can develop that relationship, like what Dr. Doherty's developed with his patients who can help with these issues. And they can be a resource available, and we can then work with you guys in the offices and social work and things like that as we develop those relationships. But I think that's very important.
I think having another adult involved in the room in the conversation, like at Samaritan Place, again, we have a caseworker go, but if there's a way to have an adult child or a sibling or something, or a neighbor go with you to hear also what's supposed to be happening, I think that's a great way to achieve a better adherence.
An observation, and that's another way to look at MCOs billing for 90 days, and if they will do the maintenance medicines for zero, that's going to free up that money so that it can then be used towards more expensive medications. And I don't think that doctors and or nurses think about asking their patients, you know, this Toujeo or whatever is going to cost you $2,400 a month. Can you afford that? I mean, that's really what we see a lot of, is the initial cost of the medication, and it's things like insulin and blood thinners and things that people have to have in order, one, to either live or to have a good quality of life. And, you know, to me, that's the biggest problem that I face working with seniors, is just the overall initial cost. I mean, you know, I would love to clone these 2 pharmacists and take them, you know, I mean, and I work with 3 different states, and so with 3 entirely different populations, but, and I'm a social worker. We work with 6. Oh,
But it's so unfortunate, you know, that we don't, like a lot of times we don't find out that price until the prescription's sent over to the pharmacy, and the pharmacy technician types it in, and then it goes through insurance, and then it comes out and it's like, well, dang, this medicine's $200 for the patient, and we're not going to label it because we don't know if the patient's going to show up to get it. And then we go online to look for any copay assistance or drug company assistance, and then we have to talk back to the doctor to let them know that the patient can afford it, and it's a communication issue. And
yeah, just to add on to that, I think a good rule of thumb in terms of physicians prescribing, it's probably a good bet that the most recent pharmaceutical rep that's been in your office having a new medication, that's probably going to be on the more expensive end. So, you know, should we maybe try that for them before you take it? Kind of, you know, so it has that
fun. I think the other thing is it's that time of year, everybody's insurances have changed, you've got new plans. I mean, my mom's got her own personal pharmacist, so this time of year, I sit down with her plan, which is Humana, and I chug through their website, and I put all her meds in and see what's still formulary and what's not. Luckily, this year we didn't have to change anything. Last year we had to change 2 meds, so to get things where they were affordable. I just went with a family member to the doctor the other day. Humalog was formulary, Novolog was not. So I'm sitting there, I'm like, give me your insurance card, and I called the insurance while the doctor's prescribing. I mean, you've got to almost have that forethought, because otherwise, if Novolog would have got called in, Dr. Doherty's pharmacy would have come back non-formulary, or it would have been like $200 and some. They wouldn't have labeled it. I would have showed up as a patient, frustrated, can't get my med. Then they got to call the doctor back. That's what, 24, 48 hours for them to return a call. And then it's just this. Who knew healthcare was complicated, right? I mean, that's as complicated as it gets. And then, you know, if I got a transportation issue, now all of a sudden I may not be able to get back to the pharmacy to pick that up for another week or two. So it's very frustrating. I agree.
I'll add one more thing in that 60% of Medicare patients that have Part B's or Medicare Advantage plans don't re-look at their plan the following year. So if you've got patients, don't let them just say, oh, I'm just going to use the same one, because those formularies change. So some of the data says 60% of those patients don't look at them year to year. And the other thing, put in your all's ear, if you're really interested in medication costs and how it affects the patient, go read about DIR fees in pharmacies and PBMs, and you might like want to run through a wall for your neighborhood pharmacist, because it's putting patients into the donut hole faster and faster every year, and it's the insurers and the PBMs that are doing it. It's not the pharmacy or the pharmacist, and it's hurting the care that our Medicare patients are receiving and are able to get. So it's called DIR fees, or direct remuneration fees. It's a big deal, and there's some bills in Congress that are going through right now. You should definitely read about them if you're interested.
Unfortunately, we are out of time. But I want to thank all of the participants in this panel and in their presentations. Dr. Boyce, and once again, thank you for your time, for your attention, and for your input as well. It's been wonderful. Thank you.